I'd like to introduce our first keynote speaker of the day, Professor Jeffrey Hausdorff. He's a professor at the Tel Aviv Sourasky Medical Center, the director of the Laboratory of Analysis of Gait and Neurodynamics at the Tel Aviv University, and a lecturer in medicine at Harvard Medical School. His laboratory investigates the neural underpinnings of gait, postural control, falls, movement disorders in health, and pathology as well, so certain conditions like Parkinson's disease and Alzheimer. We're very excited to hear his talk about insights into gait and fall risk using body fixed sensors and brain imaging. Please help me welcoming Jeff.
Good morning, everyone. Thanks, Kim, for those lovely words, and I want to thank the organizers for the invitation to participate in this wonderful conference. Yesterday was a very inspiring and interesting and informative day, and I'm looking forward to the rest of the conference to learn even more about falls. It's a pleasure to come to the land down under to learn and to see such a focused effort on this research area. So just to give you an overview of, I'm going to kind of divide this talk more or less into two pieces. First, I'm going to focus on using body fixed sensors for assessments. Then I'm going to spend some time discussing an intervention, and finally at the end tying those together using a new type of body fixed sensor that will give us some insight into brain and neuroplasticity. So just in case some of you might not be familiar with the term body fixed sensor, that's just a fancy way of saying a wearable computer or any sensor that's attached to the body. Keep that in mind. Okay, just by some of you might, after a few minutes, start to get the idea that I'm a used car salesman pushing a specific agenda. I do have an agenda. My agenda is to convince you, the people who deal with falls both in research and healthcare, that it's time to really get serious about body fixed sensors, and I think that we need to start to think about how they can use, certainly in research, which they already been used, but even to start how they can be used routinely in a clinical setting. So I'm not selling any cars. I don't have any stock in any body fixed sensor companies, but certainly the unhidden agenda is to convince you or to show you some of the ways that we can use body fixed sensors both clinically and in research. So I'm going to initially focus on the gait changes in patients with Parkinson's disease, just as kind of an illustration, and to shake things up since we're more or less focused on community living older adults and hospital adults. There was some mention yesterday about multiple sclerosis and other patients with neurodegenerative disease. But just keep in mind that patients with Parkinson's disease have many of the gait changes that we see in advanced aging or in unsuccessful aging, and indeed some have suggested that Parkinson's disease is kind of a model of advanced aging. So as you see in the video here, this gentleman with Parkinson's disease has short strides, slow gait, shuffling gait pattern, also fearful, the stoop posture, and many of these characteristics overlap the so-called unsuccessful aging. It's also important to keep in mind that patients with Parkinson's disease, they fall a lot. So we talk about the one-third of community living older adults fall one or more times each year. Among patients with Parkinson's disease, that number reaches about 70%. So they fall about twice as much as community living older adults. So again, in that sense, they can be a model for falls and understanding fall risk. So using the foot switches, back then we didn't call them body fixed sensors, but they really are a form of body fixed sensors. We noted that the patients with Parkinson's disease are not able to maintain a steady gait pattern. So if you see on the top figure here, this is the stride time, where the gait cycle duration is a function of time over about 5 minutes in a patient with Parkinson's disease, and below an age-matched healthy control subject. And you can see just visually that the patient with Parkinson's disease, they're not able to maintain that consistent gait pattern. There are stride-to-stride fluctuations. Their gait is changing from one stride to the next. And in contrast, in the patient in the age-matched healthy control, you can see that they have a much more consistent gait pattern. There still are these stride-to-stride fluctuations, but on a much smaller level. And if we can quantify that in different ways, for example, the coefficient of variation, which is much, or the CV, which is much larger in the patient with Parkinson's disease. Now, it's a little early in the morning for questions, and everyone was recovering from the beautiful banquet dinner last night. But I'm sure you're all wondering. It's a question I can see that you're all already wondering. What is the top 5 most cited papers in all of physical medicine and rehabilitation? I can see that's a question that you're all asking yourselves, right? So I did some homework, and actually last week someone sent me an email. I had no idea, but our paper, looking not at stride-to-stride fluctuations in Parkinson's disease, but looking at the relationship between gait changes and fall risk in community living older adults, is one of those. And this is a figure from that paper from 2001, published in the Archives of Physical Medicine and Rehabilitation. So I'm going to just toot my horn for 1 second, because no one else will. So my mom's not here. But so here you can see, again, similar to what we see in patients with Parkinson's disease, if we look at community living older adults, they have an increased stride-to-stride variability, and this measures derived from this are prospectively related to fall risk. And as I mentioned, this paper from 2001 was recently cited among a review, which the top most cited papers in physical rehabilitation and medicine. And you can see it beat out the original Get Up and Go paper, which was number 4. So pretty exciting. Anyway, just share that as an aside. Okay, coming back to patients with Parkinson's disease and body fixed sensors, some early work again with foot switches. Just to summarize some of the insights that we gained using those foot switches, we found that certainly there are marked changes in advanced disease, but even in early patients with Parkinson's disease who visually you don't see marked changes, you can already quantify increase in gait variability. Gait variability becomes worse or more exaggerated dual tasking, and we'll come back to this again at the end, which is really important to keep in mind. It's associated with fall risk. As we see in community living older adults, it responds to medications and deep brain stimulation, which is kind of the treatment for advanced patient with Parkinson's disease. And it also responds to other interventions like treadmill training, and again, we'll come back to that in a little bit. But one of the, I think, important lessons that we gained from this early work in using foot switches or body fixed sensors is that when we think about gait, gait is not a unimodal construct, but rather gait, I like to use the parallel to cognitive function. We all know when we think about cognitive function, there are multiple constructs. We can think about a global measure. Perhaps we can capture that with the MMSE or the MoCA, but really that just reflects different subdomains or constructs. We think about memory or executive function or attention or information processing, and we know that they're related to each other, but they're really distinct domains. And the same thing can be said about, when we talk about gait, we might think about mean values of gait speed or stride time, but then there's a different construct that relates to variability or rhythmicity or fractal properties or phase coordination. All of those are clearly, one is related to the other. They're all the same brain, same body, same CNS. But we need to, when we think about describing them and about therapies and full risk, it's helpful to also think about the independent nature of those different constructs. So more recently, work in our lab and in other places have kind of moved from foot switches and started to use accelerometers. They're very easy to use. These are, again, some of the accelerometers that we use in our lab. We don't have any invested interest in any of these. They all have different pros and cons. And just one of the ways that the nice thing about accelerometers is you can slap them on using double-sided tape or a belt. And now we can really very quickly augment performance-based tests. So we all know about, for example, the timed up and go, which is a widely used measure of physical performance and mobility and has been associated with fall risk in various populations. And here you can see an acceleration signal during the timed up and go, and already by eye you can see very easily pick out the different components, the sit to stand, the walk, the turn, the walk again, and then the transition back to the sitting position. And now, one of the beauties of the timed up and go is it takes only a few seconds, 13 and a half seconds and above for someone with fall risk, maybe a minute for some of our patients who have severe freezing of gait. Sometimes get stuck, it takes them a minute, but even so, it's very quick to do. You get a single outcome, and it tells you a lot of information. But if we think about sensitive markers of fall risk and sensitive markers of response to interventions, it gives us, this timed up and go gives a global measure. It doesn't really tell us what's happening during these different components. And clearly the requirements for sit to stand, for walking, for turning, they overlap, but they're different demands. now that we can quantify each of those different components of the time dip and go using an accelerometer, we can pick out and characterize each of those different components of the time dip and go. So for example, just in one early work where we compared the acceleration range in sit-to-stand in healthy controls to patients with Parkinson's disease, you can see that healthy controls, sit-to-stand and stand-to-sit acceleration range is very similar. If you're fighting gravity or using gravity in healthy controls, the acceleration is more or less the same. Patients with Parkinson's disease, when they are using gravity, when they go from stand to sit and use the technical term, when they plop down in their chair, they have no problem doing that. It's similar to what we see in healthy controls, but when they're fighting gravity, when they're getting ready to go from the sit to stand position, from sitting to standing, you see they have a real problem generating acceleration, and it's markedly decreased both compared to healthy controls and to the stand to sit. So this, again, can give us some added value into these performance-based tests, which are widely used for full risk assessment and for monitoring in the clinic. Now, but I think the real excitement, or one of the real excitement, is going beyond that. So when we do performance-based tests in the lab or in the clinic, it gives a snapshot view of what the person can do. Usually we try and motivate them. We ask, and we test them in the lab or the clinic, and this gives us a quick view of what they can do. But as was mentioned yesterday in one of the sessions about white coat syndrome, there's reverse white coat syndrome, and patients with Parkinson's disease suffer from what's called motor response fluctuations, and their abilities are fluctuating throughout the day. So a single test at a single time point may not really accurately reflect their abilities. So one of the beauties of accelerometers and body fixed sensors is now, instead of just assessing their performance over a short period of time, at a single time point, we can use them to assess not just what they can do, but also what they do. So we can use them to continuously monitor for 3 days, for 7 days, for 2 weeks, for several months, using a single body fixed sensor, which provides much more information and how these things change over time, from day to day, from hour to hour as well. So initial work on this, we had patients with Parkinson's disease walk throughout our medical center on a kind of a prescribed tour. They walked through down some crowded hallways, outside, over stairs, through the bookstore. And we asked, while wearing a body fixed sensor, and we asked whether or not we could extract meaningful data, similar to what we've seen in the laboratory circumstances where things are well prescribed, whether or not in this kind of cloudy and muddy environment, test conditions, whether we can extract meaningful data. So here you can see a snapshot of 10 seconds from that several hours of walking. On the left, a patient with Parkinson's disease, on the right, a healthy age-matched control. You can see these fluctuations in the acceleration signal for each step are clearly discernible. But now, instead of looking at time from heel strike to heel strike, which we looked at in using foot switches, now we transfer that signal in the Fourier domain. It's not really, the details are not so important. But one way of looking at the consistency of the gait pattern is by looking at what we see on the bottom row here is a frequency representation of that signal. And basically the idea is that the sharper that peak, the more narrow that peak is, that reflects a more consistent gait pattern. So you can see again, in this, for this example of this patient with Parkinson's disease, you see that this peak is more narrow, more broad, reflecting an inconsistent gait pattern. And basically what we saw in that first slide about those large stride fluctuations, this is another representation of that over this 10-second snapshot. But the beauty is now that we can go not just based on 10 seconds, but we can have these mountain plots over, for example, in this slide, over 72 hours. So again, here you can see in the patient with Parkinson's disease, the peaks on these mountains are much shorter, they're broader compared to this age-matched control. And we've seen this on a group level as well. So it's time, I think, to think about using this in a clinical setting. I know in Norway, I believe in some of the geriatrics clinics, are already using body fixed sensors and accelerometers for long-term recording as routinely in some of their outpatient studies. We use it routinely in our research, not in our clinic just yet. But what we can easily do is we can use this for automatic detection of different activities, resting, lying, sitting. For example, here we can automatically detect if the subject is lying, sitting, standing, or walking, and use that to here you see a barcode representation of those different activities. In this study of patients with Parkinson's disease, we studied about 110 patients with Parkinson's disease prospectively looking whether or not activity is related to fall risk. We found very similar activity patterns in patients with Parkinson's, fallers and non-fallers. So the amount of activity was very similar. Both fallers and non-fallers were couch potatoes, spending most of their time lying down or sitting and very little time walking. However, if we look at these mountain plots again, which reflects the consistency of the gait pattern over time, you can see that those peaks are much, again, the peaks are shorter and broader in the patient with Parkinson's disease. In this example, again, reflecting the more inconsistent gait pattern. And we find this on a group level, and here you see that based on a prospective prediction of future falls over a 1-year follow-up, we see that above that fall history and the UPDRS, the Unified Parkinson's Disease Rating Scale, which is a clinically based measure of their motor activity, motor abilities, we find that those two measures do a decent job of accurately identifying who's going to fall in the future. But when we add acceleration-derived measures based on 3 days of recording, we improve our accuracy, sensitivity, and specificity. Now, there's an interesting phenomenon among patients with Parkinson's disease, similar to what we find in community living older adults. One of the best predictors of future fall risk is if the simple question, have you fallen in the past? And that's true in patients with Parkinson's disease as well as community living older adults. So we challenged ourselves a little further and we said, can we identify the de novo, the first-time fallers? Let's take that subset, about 70 subjects in this study who reported no falls in the past year. And here you can see, again, if we divide those subjects who reported no falls in the previous year, we divide them up based on the width in those mountain plots. You can see that above the blue line are those subjects who had a relatively low width or had walked with a more consistent gait pattern over a 3-day recording. The y-axis is the percent of subjects that did not fall. So again, at baseline, no one fell. Everyone reported no falls. And you can see that there's a clear difference between the fallers and the non-fallers, or time to fall, based on the width of those mountain plots, suggesting there's some added value beyond just the conventional measures. In contrast, if we just look at gait speed is one of the hallmarks, reduced gait speed is one of the hallmarks of patients with Parkinson's disease. Here you see the survival curves, and basically there's no difference between high or low values of gait speed in relation to fall risk. So there's some specific new information that we can get from accelerometers and body fixed sensors. So we really think that we should be thinking in a clinical setting is that we can send out these body fixed sensors there. Some of them are about the size of a stamp. They weigh less than a matchbox. We can send them to subjects by mail, by post, and then they can collect some interesting data based on 72 hours, a week, or 2 weeks, and we get some information about how they're doing, how active they are, summarize that, and tell them, Mr. Jones, you need to be more active. And we can also have the number of steps per day, the cadence, or measures of gait speed, and we can also think about different constructs related to fall risk, gait variability, symmetry, missteps. We might have norms, and we find out if the subject is outside the norms or not. And we can also think about different levels of time to intervene or not. So that's one way where this is a technology that is already there and can be used in clinical settings to basically generate a detailed description of the subject's activity and motor performance even before they take one step in the clinic. But another, I think, very exciting way is to use body fixed sensors as a tool for therapy. So one project which was mentioned in one of the talks yesterday is a project called Weasel, which combines force-sensitive insoles with an accelerometer and a gyroscope all inside an insole. It's combined with real-time feedback on different levels and telemedicine, which provides feedback to the user, to the subject, and as well to the caregiver to improve gait and potentially reduce fall risk. Another project, specifically in patients with Parkinson's disease, combines technology using accelerometers, this time placed on, actually embedded in the shoelaces. It's designed to improve and deal with the freezing of gaits, to provide biofeedback for gait training, and also use the same technology for virtual reality-based exercises. So here's an early prototype of that system. It uses, the idea is that the clinician can set different parameters, saying now I want to exercise cadence or stride time or variability or asymmetry. The clinician can set the different, decide when to provide the feedback. Is it every step, every 5 steps, every 10 steps? And there's kind of a library of values, and whenever those measures go outside the window, then there's feedback given. So the beauty of this is now, instead of asking the subject to come to the clinic, we have basically the clinic come to the subject, even using the technology to provide feedback, and as if the physical therapist is walking with them. So here you see an example with a patient with Parkinson's disease. He's placing those sensors in his shoes or in his sneakers, commenting on how they use. Here he places, in this scenario, we have 2 sensors on the shoes, 1 on each shoe and 1 on the lower back. He turns on the system, and then he uses the smartphone app to select various exercises, which are set. The parameters can be set remotely by the clinician. And what's interesting, and he commenting on his initial use of it, he actually was very intrigued by, he comments on the positive feedback. We all usually think about, patients getting feedback that they need to stand straighter or need to walk with bigger strides, but he's actually very intrigued by the positive feedback. Here you can see him using an exercise designed to help him with freezing of gait. He turns to go to the bathroom to go through this doorway. His feet get stuck, and actually you can't hear it, but he has a metronome goes off to help him get out of that freezing of gait. And one of the beauties is that this can be done anywhere. So here he's walking out for his afternoon stroll. Again, we didn't turn the audio on, but you can see the feedback that's given automatically by the system, telling him he's walking well or he needs to slow down, compared to the library of parameters. We also can combine it with Google Map to make things a little bit more challenging cognitively. And we're very excited about this tool, which can really help people train in a much more extended period of time. So here, just summarize some initial results, and based on a small pilot that's ongoing in 14 subjects. You can see mean values of walking speed, step length, and the 2-minute walk all improved. And I just want to anecdotally tell you about Uri. Uri is a 77-year-old gentleman who was a professor of engineering. He was diagnosed with Parkinson's disease about 15 years ago. And as you might know, many patients with Parkinson's disease, once they start to deal with the disease, they lack initiation. They want to stay in their familiar settings. They don't really move beyond their local environs. And Uri had not left the country for 15 years since he was diagnosed with Parkinson's disease. And here you can see one day after he trained with this system for 6 weeks, he decided to surprise his wife. He bought tickets to Paris, and here you can see them at the Eiffel Tower after using the system. So very anecdotal, but if we want to make impact on quality of life, this is one way that we can think about that. So body fixed sensors, just to kind of summarize, I think they can use to provide us a complete motor exam even before the patient steps into the clinic. They can be used to augment the clinical exam. People have thrown out the ideas of iTug or ISPPB or iSway. Other performance-based tests can be augmented, and they also can be used as a vehicle for therapy. So I'm now going to kind of switch gears and talk a little bit more about intervention that I've been working on using virtual reality for treadmill training, and then we'll tie it back together to body fixed sensors at the end. So if I asked physiotherapists or geriatricians to describe a formula for safe gait, if I asked them maybe 10 or 20 years ago, I think most of us would agree that this is a kind of a simple formula that we'd use if we want to have safe gait or gait without falls. We need just 2 components, very simple: intact motor system, intact sensory system, and then people are able to ambulate successfully without any falls. But hopefully you would all agree, based on lots and lots of work on dual tasking and related works, that this is an oversimplification, and we need to add an important component to this equation. When we think about everyday walking under challenging conditions, if you want to get from one side to the other, even healthy young adults, we need cognitive function. We need specifically attention, executive function, decision-making, adaptation, dual tasking, and obstacle negotiation. For example, if we want to get healthy young adults want to get from one side of the street to the other. And even, especially this is even true in older adults or patients with neurodegenerative disease where their usual walking abilities are impaired. So cognitive resources are really important. So with that in mind, we developed a multifactorial treatment approach that combines motor training with cognitive function. For the motor training, we use a treadmill. For the cognitive training, which is done at the same time we use focus on obstacle negotiation. And the idea is to use gait training that promotes motor learning while introducing graded motor and cognitive challenges tailored to individual needs. So it's based on principles of motor learning. And the way that we achieve this is by having subjects walk on a real-life treadmill, so they're working on their motor control while they're embedded in the virtual realities. You can see here the screen where the subjects walk. They wear a harness, so the safety harness, so that we can challenge them without any risk of falls. We use a Kinect to measure what their feet are actually doing, and when we place the image of their feet in this walking in this virtual environment. And the beauty is in the walking in the virtual environment is that we can manipulate the difficulty, the task difficulty. We can change the frequency of the obstacles, we can change the height of the obstacles, we can change the types of the obstacles, we can change the number of distractors, the weather environment, and all these things to make the task motivating, challenging, interesting. And of course, we also provide feedback on the scores, so it's really a game that subjects perform, but at the same time while they're working on their dual tasking, they're planning, they're scanning, the obstacle negotiation, as well as their motor control at the same time. So it kind of reflects real world abilities, but we can grade and change the degree of difficulty and the challenges. So here you can see a snapshot. This is from one of the first studies that we did using this idea in 20 patients with Parkinson's disease. You can see their mean disease duration about 10 years, so they have fairly advanced disease. And on the left, you can see a patient with Parkinson's disease about in the beginning of training. Notice she holds onto the railing. And you're all familiar with the stops walking while talking phenomenon. This is, we call this the stops walking while negotiating obstacles. Not quite as catchy, but get the idea. Basically, an obstacle comes and she has to stop, almost stops walking on the treadmill. She's not able to plan ahead. She's not able to deal with the obstacle. She does one or the other. She walks and deals with the obstacle. Can't do both at the same time. And here you can see the same woman 6 weeks later after training on the system. You can see the obstacle comes along. She's not holding on to the railing. She steps over the obstacle and goes on her merry way. So it's a very different type of behavior. Here she's successfully able to walk and negotiate obstacles. And on a group level, you can see here the changes in gait speed during usual walking, dual task walking, during 6-minute walk test, and I could add a fourth column during obstacle negotiation. This is all measured over ground. And you can see that after 6 weeks of training 3 times a week, their gait speed on all these conditions improved. And what's really interesting, again, keep in mind these are patients with Parkinson's disease. When we tested them 1 month later, we can see that actually gait speed continued to improve. You would expect that their gait speed returned to baseline values, but actually we find that we suggested maybe some kind of behavioral change, positive feedback, and gait speed values continue to improve even after completion of the intervention. In this slide, we compare the work with virtual reality, the intervention with virtual reality and treadmill to a previous study that we did using a very similar paradigm. Actually, in the earlier study, it was even more intense. It was subjects were trained 4 times a week compared to 3 times a week. And you can see that the percent improvement in gait speed and stride length were very similar in the subjects during usual walking, in those subjects who trained with virtual reality, without virtual reality on the treadmill. The real added value of the virtual reality training is during dual tasking. When subjects walk on a treadmill without virtual reality, there's basically no improvement in gait speed or stride length. In contrast, there are large improvements in gait speed during dual tasking of gait speed and stride length during dual tasking on the subjects who participate in this virtual reality training, which really allows them to implicitly work on their dual tasking, on obstacle negotiation, and other cognitive resources. In fact, when we look at the trail making test A and trail making test B, trail making test A is a test of visual scanning. Trails making test B is a standard test of executive function and task switching. We see that subjects who participate in this virtual reality with treadmill training, they improve their cognitive function as well. Again, we see nice retention and nice transfer to what a test that's not explicitly trained. We've looked at this in other patient populations. For example, we've done work in multiple sclerosis. This is one result where we see that the time to McGo was significantly reduced. We've looked at work in idiopathic fallers, and you can see that in this example, in this very small pilot study, all the subjects were multiple fallers to begin with, and after participating in this intervention, they became non-fallers, or non-fallers or single fallers. We've also recently started looking at children with ADHD. They're kind of a flip side of what happens with Parkinson's disease. We know children with ADHD have mild changes in their motor abilities, and they have significant problems with attention, and we asked whether or not we can improve their attention abilities using this virtual reality with treadmill training program. And you can see baseline values were all far below the 100 value, which is an age-matched norm, and you can see that executive function and even more markedly attention significantly improved in response to this treadmill training with virtual reality. So based on this initial positive experience, we said, well, maybe it's time to translate this experience into clinical practice. We developed some new VR simulations. We added some levels of distraction. We added an urban environment. And we opened up this clinical setting where we can train 4 subjects at the same time, as shown here. Here's some summary statistics on the first 60 subjects. We've now are up to about 100 subjects who are participating in this clinical intervention. You can see there, not surprisingly, most of the subjects have reported multiple falls. After training in this clinical setting, we find that the 2-minute walk times improve, so there's endurance, motor control improves, and as well that we find significant reduction in time dip and go, and in the 4-square step test, which is a measure of overground obstacle negotiation abilities. Again, this is based on a clinical study now implemented by physical therapists in a clinical setting. So that's very exciting that we can transfer this research into the clinical setting. And just anecdotally, all those subjects who participated were very positive, and they basically reported changes not just in their functional tests, but also in what they're actually able to do from day to day. So what I've shown you so far in terms of this virtual reality with treadmill training is that it appears, based on these small studies, we're able to modify fall risk mediators, whether time to go or gait speed. But one of the big questions we know if we weren't interested in falls is, can we actually reduce the number of falls? So to answer that question, we initiated with funding from the European Union. A couple of years ago, we started a project called V-Time, which is designed to specifically as a primary outcome to address whether or not we can use this system, this intervention, to reduce the number of falls. The goal is to recruit 300 community living older adults, and they're randomized either to treadmill training with VR or treadmill training without VR. Today we've studied 270 subjects have completed training, and we have a number of measures that are assessed immediately post-training, 1 month later, and 6 months later as well, to look at retention. And of course, the primary outcome is falls during a follow-up period. As I said, we use technology, so we developed a smartphone-based application for fall risk reporting. Subjects just press yes or no if they experienced a fall on each day. This is supplemented, of course, by the traditional calendar method and phone-based measures. We'll, of course, measure gait using a gait mat, cognitive function using neuropsych testing. fMRI, we're very interested in understanding neuroplasticity, and we use one of those body fixed sensors at each time point, pre, post, 1 month, and 6 month follow-up. Where subjects were there continuously for 7 days. Now, and as a secondary outcome measure to give us insight in what happens in the brain, we also use this body fixed sensor, a different type of body fixed sensor. This is called FNIRS, or functional near-infrared spectroscopy. It's basically a poor man's version of fMRI, but the beauty of this system is it uses the same principles as fMRI, but now instead of having the subject to line in a magnet, we can actually have them walk and do a task at the same time. Now, this study is ongoing, and as I mentioned, we have about 280 subjects who have completed training, but there's still about 20 subjects to go, and the CRO won't let us decode. We can't tell you who has done what, but I can share with you some interesting results about changes in frontal activation using the FNIRS during training. So here you can see on the y-axis is the change in blood oxygenation in the dorsolateral prefrontal cortex, or Brodmann's area 10. That's the area that's responsible for task switching and executive function. At session 3, session 9, and session 18, this is just in the subset of patients with Parkinson's disease. And you can see when you compare at session 9, there's a significant increase in the frontal activation compared to session 3, and that trend persists at session 18. Now that looks very exciting, and for those of us who are, it's really very exciting to see that there's potential changes in brain plasticity as a function of this intervention. But I think for those of us who have experience using fMRI and FNIRS know that sometimes there can be multiple ways to interpret the same results. So just want to spend a couple of minutes and before I conclude to convince you that this is actually a good thing here, what we see, and it's a beneficial change in brain activation. So we'll take a small tour. Here you can see the FNIRS signal in the subject during usual walking, and there's very little going on, very little changes in the blood oxygenation. In the middle, you can see what happens during dual tasking. Activate that. And now you can see these marked changes in the blood oxygenation, which actually appear to be event-related when the subject says the serial subtractions out loud. You can see these large changes in blood oxygenation. And similarly during obstacle negotiation, you can see that when the subject walks over these boxes, there's these large changes in the FNIRS signal. Okay, and then when we looked at this, we and others, Roy Holter from New York, had looked at this in healthy young adults, and you can see during usual walking, there's very little increase in blood oxygenation. During walking and counting, a simple task is a small but significant increase. During walking in a more significant, more difficult task, you can see there's a significant increase in the FNIRS signal. Significant reliance on cognitive resources or executive function when subjects are asked to basically walk and do a difficult cognitive task. And here we compare what happens during usual walking in healthy young subjects, healthy older adults, and patients with Parkinson's disease. You can see in healthy young subjects during usual walking there's very little frontal activation, as one might expect. They're using mostly motor resources to control their walking. In older adults, there's a small but not significant increase. In patients with Parkinson's, you can see there's a marked increase even during usual walking. They're relying on their cognitive resources to compensate for their impairment in their motor function. But what's really interesting, what happens if we look at what happens during dual tasking. You can see in healthy young subjects, when they're asked to walk and perform a difficult dual task, they have a marked increase in their FNIRS signal. They're doing dual tasking. They're using their dorsolateral prefrontal cortex to deal with that, to task switch, and there's a marked increase in their FNIRS signal. Similar result in healthy older adults, but what happens in patients with Parkinson's disease, they're kind of saturated out. They're already at a ceiling effect. They're not able to recruit additional cognitive resources, and there's no change in their FNIRS signal during dual tasking. And if we over that with gait variability, you can see healthy young adults, when they're asked to walk and perform a difficult task at the same time, no increase in their gait variability. Healthy older adults is a small increase, but not too bad. Health and patients with Parkinson's disease, in contrast, you can see they already walk with increased variability to begin with, and then when they're asked to walk and perform another task at the same time, there's a marked increase in their gait variability. So to go back to this slide, are we seeing beneficial changes in their dual tasking ability and their frontal activation? I would argue yes. In session 9, subjects are able to recruit more cognitive resources involved in call into play the dorsolateral prefrontal cortex, which persists during session 18. So just to summarize some of the advantages of using virtual reality with treadmill training, allows subjects to train using their attention, their problem solving, ongoing adaptation, planning. It allows for multiple repetitions in a well-defined setting, but a diverse training environment. We've had over 95% adherence in our both clinical setting and in the research setting. Subjects find it very engaging and motivating. It's applicable to a diverse patient populations. There appears to be improvement in gait and balance in performance of complex tasks. There's task-specific training as well as transfer to untrained tasks, and most importantly, retention as well. So when we combine treadmill training with obstacle negotiation, we find, of course, that both treadmill training and obstacle negotiation improve, but also there's important transfer to cognitive domains and even to functional domains and as well to brain plasticity. So body fixed sensors, just to very quickly summarize, we find that they They can be used to augment performance-based tests like the timed up and go. They can be used for long-term monitoring of activity and fall risk. They can be used as to provide gait training and biofeedback, and have the physical therapist walk with the subject using technology. And they can also be used in the form of FNIRS to provide insights into brain plasticity. So with that, I want to thank all the people who carried out this work, funding agencies, and thank you for your attention.